Oh, she's here. Brilliant. Okay, so Dr. Sandal is going to talk about the study of next generation sequencing in unexplained intellectual disability. Thank you. You can come here.
Good morning, everyone. I am a clinical geneticist from India, and our study was next generation sequencing in unexplained intellectual disability. And as we all know that intellectual disability is a common neurodevelopmental disorder with a reported worldwide prevalence between 1 to 3%. And in 50% it is non-genetic in origin, and in next 50% there is an underlying genetic etiology. And using our currently available standard genetic tests, we can achieve a diagnosis in up to 20%. Still 30% of the cases they remain unrecognized. And the recent evidence it suggests that exome or genome based tests can be used as the first tier or second tier test for ID, and with a diagnostic yield of up to 38%. But still there is a lack of data from our country, India, and so we planned this study with the aim to find the diagnostic yield of NGS in patients with unexplained ID, and further to assess the utility of a definitive diagnosis on the management and genetic counseling of these families. So we carried this study over a period of 3 years with a retrospective and a prospective cohort, and we enrolled patients who had moderate, severe or profound ID in whom we were not able to make the diagnosis after standard genetic tests. And we excluded patients who had acquired or environmental causes of ID. So in the retrospective cohort, we have a total of 101 patients, and in prospective cohort, we have 126 patients, so accounting a total of 227 patients with a mean age of 4.5 years. These patients we further classified as isolated ID or ID plus conditions, and we performed various kinds of NGS tests. So moving on to the results, the overall diagnostic yield in our study was 53.7%, and we didn't find any difference between the prospective and retrospective cohort statistically. And the majority of the patients in our study, they had ID plus associated phenotypes like autism, seizures, dysmorphism, malformations, and abnormal head size, and only 7% they have isolated ID. So we found that the patients who had ID plus conditions, in them the diagnostic yield was significantly high, 56%, compared to the patients with isolated ID in whom we would achieve the diagnosis in only up to 20%. And this is in accordance with the studies which have been reported in the literature. And the most common were the dysmorphic syndromes like Coffin-Lowry, Coffin-Cyrus, Rubinstein-Taybi, and the Cohen syndrome. And the other major group was the developmental and epileptic encephalopathies, which we found in our study. And we found the variants in total of 84 ID genes, and the autosomal recessive ID was the most common with a significant burden of homozygous variants. And the autosomal recessive ID accounted for a total of 44%. The next was the autosomal dominant ID and then the X-linked ID. So when we compared our data with the Western, where there is predominantly an outbred population, they are rich in de novo dominant variants. And the autosomal recessive ID genes, they contribute merely up to 12%. And they have a predominance of the compound heterozygous variants. And if we look at the countries where the consanguinity is high, the diagnostic yield can reach up to 60%, and they have a huge burden up to 70 to 90% being the arid genes, and with the burden of homozygous. We lie somewhere in between. In our cohort, the consanguinity was in 16%, and the arid genes, they contributed 44%. Moving on to when we look at the impact which was made by the diagnosis, so we were able to do the active clinical management in terms of modification of medication, modification of diet, and the supportive care and medications for a total of 15 patients. And they were predominantly the patients who have developmental and epileptic encephalopathies and metabolic disorders. In terms of long-term management, surveillance recommendations, they were given for the 2 patients, and 48 patients, they were referred to other specialties. For 26 families, we offered prenatal testings, and we found that the 6 fetuses, they were affected. And for 1 family, we advised them not to use a particular drug. So I conclude by saying that still we were not able to achieve diagnosis in 46% because of the inability to perform the functional tests. And we have extensive genetic heterogeneity, finding a total of 80 variants in 84 ID genes. We have a high burden of autosomal recessive ID, and which we attribute 1 to the consanguinity, and second to the practice of endogamy, which is prevalent in our society, and third, that the ID plus assured phenotypes, they actually results in a higher diagnostic yield. Thank you.